Welcome to the We Shine Well podcast, where I have real conversations with thought leaders in wellness to help you live your most vibrant, aligned, and purposeful life. I'm your host, Zoe Kelsey, founder of We Shine Well. Here, we share honest stories, gems of wisdom, and insight to spark clarity and guide your next right step so you can shine brighter from the inside out. Now let's dive in. Today, on the We Shine Well podcast, I am joined by someone who is reshaping the way couples view their fertility and their options. Dr. Sasha Hakman is a dual board-certified reproductive endocrinologist, known for her evidence-based yet deeply compassionate approach to reproductive health. She bridges medical expertise with lifestyle optimization, helping women understand their fertility in a clear, empowering, and grounded way. She is the host of the popular podcast, Trying to Conceive with Dr. Sasha Hakman, and her insights have been featured across major publications, podcasts, and platforms. Sasha is driven by one mission: to give women the knowledge they need to make informed decisions about their fertility, from their teens and 20s through motherhood, perimenopause, and beyond. In today's conversation, we talk about how genetics and lifestyle truly influence fertility, the real differences between natural conception, IUI, and IVF, and what women should be thinking about at every life stage, whether you want kids someday or you're actively trying. This is a grounded, hopeful, and clarifying conversation that every couple deserves to hear. Let's dive in. So excited to have you on the We Shine Well podcast today. It's been such a pleasure to get to know you over the past year, both personally and with the depth of knowledge you have. And I'm so excited for this conversation to just share your journey and all of the incredible knowledge that you have.
Thank you. It's such an honor to be here. I still remember our first conversation, and it's amazing how our relationship has developed over time, and both working on a personal and professional level together. It's been great.
Yes, I couldn't agree more. And it's just incredible to just listen to other podcasts and your podcast, and just hearing the depth of knowledge that you have and the impact that you're making. And you don't just have one board certification, you have two, as in I'm not going to pronounce this right, but obstetrics and gynecology. I will let you pronounce this.
Obstetrics and gynecology. I know it's a mouthful.
There you go. I just say OBGYN all the time.
Yes, exactly.
And reproductive endocrinology and infertility. So can you share a little bit more about your background? Like, when did you even know that you wanted to go to medical school and then even specialize in what you have today?
So funny enough, and I know that I've told you this story before, but I originally wanted to go to culinary school and become a chef. I love cooking. I'm good at it. I love baking. I probably would have specialized more in just being a pastry chef, but I was always very good at science, and I am really good with my dexterity. So my dad really encouraged me to highly consider going to medical school. It's like, you can always cook at home. You can pursue that passion on the side, but to be a doctor, you have to go through the education system, through the formality of it all. And I think that the world needs a surgeon like you. You would be an amazing surgeon. So I sort of followed his advice there, and I did go to med school. And I originally went to med school with the hopes of becoming a general surgeon who would then specialize in breast surgery, primarily for breast cancer patients. So that was my ultimate goal. So yeah, once I was in med school and I was rotating through the different specialties, I realized that I really loved OBGYN just because of the breadth and depth of the specialty, where you get that continuity of care with patients and build relationships. But you also got to do surgery and do deliveries. And there's something so special and magical about deliveries. They just never get old. But I ended up subspecializing anyways in reproductive endocrinology and gave up obstetrics altogether, but I absolutely love the subspecialty.
And how has your own, I know that you have also had IVF yourself as well. Did you have your babies before you went into the specialty or after?
So after, when I was in fellowship training to become an REI, which stands for Reproductive Endocrinology and Infertility, I decided to preserve my fertility. I was 32 years old at the time, and I knew that my husband and I would start trying when I was a little bit older, and I wanted a bigger family. So we went ahead and created embryos at the age of 32. It was just there mostly for backup, but then when we actually started trying, I already have a condition which is a mouthful. It's a rare genetic condition that causes an enzyme deficiency known as non-classical congenital adrenal hyperplasia. It sort of mimics PCOS, and so it causes ovulatory dysfunction. So I started treatment right away to get my ovulation patterns in place. And after several treatment cycles, including IUIs, which stands for intrauterine insemination, I did not conceive. And so that's when we made the decision after 6 treatment cycles to move forward with an embryo transfer. And that's how I got my first baby.
Wow. And how do you feel like your own lived experience has influenced how you are as a practitioner and work with your clients, or even like other kind of like modalities that you've brought in to support them?
So it's definitely helped a lot because as my patients are going through their treatment cycles, I've kind of been through it all. I've had a spontaneous pregnancy the second time. I've had an IVF pregnancy. I've had a C-section. I've had a vaginal delivery. I've gone through the injections. I've gone through ovulation induction. I've gone through IUI, and I've done the entire evaluation piece, which includes some not so fun procedures like, for example, HSG, which helps to tell if your fallopian tubes are open or not, and helps us evaluate the cavity of the uterus. And so having gone through it, I'm able to modify things a little bit to make things more comfortable for my patients. I'm also able to tell them, hey, when you get this medication, expect that it's going to burn a little bit, or this is what this feels like. At least this is what it felt like for me. And patients always tell me that they love that I've gone through it, not because they want other people to go through it, but more so that the fact that their doctor has been through it makes it easier for them to relate to me. They really trust my opinion and things because not only do I have the expertise, but I have the lived experience, which can be really tough as you're going through something so vulnerable with a physician who does not understand physically how things feel. So it's, the feedback I get is that it's nice to have that relatability.
I mean, I can imagine you just become more at that level and relatability in such a vulnerable time of what these couples and individuals are going through at that time. And you've spoken about wanting to change about the conversation around fertility. Why are so many women told that they are infertile these days?
Well, I think that there's so much focus on the women, but the reality is there's a lot of men who are also being told that they're infertile these days. And the rise of infertility is definitely there. In the past, we used to say that 1 in 10 couples suffered infertility. The reality is that now 1 in 6 heterosexual couples will suffer infertility. But the definition of infertility has also changed because there are many different types of families that exist as well. So, for instance, if you're in a same-sex partnership, then you are going to need some assistance in creating your family one way or another, depending on how you want that to look. So for same-sex female couples, it could be as simple as getting donor sperm and doing an IUI, or it could be reciprocal IVF, where we retrieve the eggs of one partner and the other partner carries the pregnancy. For same-sex male couples, it's a lot more complicated, of course, because there's no uterus and there's no eggs. So now we need the help of an egg donor, and then it's a matter of deciding whose sperm is contributing, and sometimes it's both, as well as getting a gestational carrier to carry the pregnancy for the couple. And so that's using assisted reproductive technologies. There's also embryo adoption. And so the definition has now changed to say, okay, infertility is after 12 months of unprotected sex, there is no conception. And 6 months if you're 35 and up. And if you're 40 and older, then really after 3 months of trying, you really need to get in and at least get an evaluation and probably may need some assistance just because of the age-related effects on reproduction. But then it also includes anyone with a history of a medical condition that may make it more difficult to conceive. So if you've already been diagnosed with PCOS or endometriosis, you should probably get in sooner. And then those who have any circumstance that makes it difficult to conceive, such as being in a same-sex relationship, knowing that you don't have a uterus or whatever history that you have that you know will make it difficult to conceive naturally. So the definition is a lot wider now, and so it captures a lot more people. And it doesn't necessarily mean that the answer is IVF by any means. Like, I see a lot of patients, and I know that I'm totally going off on a tangent from your original question, but I think it's important for people to know that, you know, you may have infertility, but it doesn't necessarily mean that you need more advanced treatment. I have a lot of couples that it's something as simple as ensuring that ovulation takes place. For women, the number one most common cause of infertility is ovulatory dysfunction. And so if we can reinstate ovulation, it could be something as simple as giving you medications to ensure ovulation takes place and timing intercourse in the fertile window, or just you can have as much sex as you want, then hopefully you get pregnant, and then you'll never have needed any other intervention.
Yeah. Well, and to that point too, how do genetics and lifestyle play a role in fertility? And like, what are all those factors in the larger pie of that contribute to fertility and ultimately having a baby?
So it's definitely a combination of both genetics and environment, and part of the environment includes our lifestyle. So we know that, for instance, in 30% of all infertility cases, it is female only factor. Okay. And the number one cause of female infertility, like I said, is ovulatory dysfunction. But of causes of ovulatory dysfunction, the number one is PCOS, which is polycystic ovary syndrome. So this is an endocrine disorder that causes basically this disconnect between brain signaling and ovarian signaling that allows you to recruit an egg and release it. It presents usually with a combination of high androgen levels, really high ovarian reserve, and irregular periods. On ultrasound, usually you will see polycystic ovaries, which has nothing to do with cysts in the ovaries. It just means you have a ton of follicles that are visible on ultrasound. And follicles are basically containers for your eggs. Most of them are microscopic in the resting stage, and they can't be seen on ultrasound. But the ones that rise to the surface of the ovary that are visible on ultrasound look like these black little bubbles. And a normal count for that is usually somewhere around 10 per ovary, depending on your age. But in PCOS, sometimes I will be counting 40 to 50 follicles per ovary, which is a substantial amount. And so it makes it hard to recruit and release an egg. Now, the cause of PCOS is unknown, but we know that it's a combination of your genetics and your environment. There's definitely a high genetic component. You tend to see it in families. There's also a high association with familial diabetes, for instance. And we know part of PCOS, a lot of these women will have insulin resistance or prediabetes. So in that particular case, lifestyle can worsen the disease or even sometimes cause its onset. So if you have a genetic predisposition and you have a particular lifestyle, that combination is what can result in disease presentation or the phenotype that we see. So if women are eating ultra processed foods on a regular basis, dealing with overweight or obesity, those things can further contribute. And we also know that if you have PCOS, not necessarily caused by lifestyle, you can improve it through lifestyle. And that includes resistance training in combination with cardio. Lifting weights here is critical because lifting weights with what we call progressive overload, meaning every time you work out, you're lifting heavier and heavier or higher reps or higher sets, number of sets, that will cause a need for your muscles to hypertrophy. And muscle hypertrophy is really great for hormone health because it's reducing circulating testosterone levels, which is often a culprit, particularly in PCOS, and can reduce insulin resistance, making symptoms a lot less severe. And we also have newer research showing that endocrine disrupting chemicals can also cause the onset of disease if you have a genetic predisposition. and also worsen it. Eliminating endocrine disrupting chemicals, which we see in our household cleaning products, we see in our laundry detergent, we see in our makeup, in our hair products. Fragrances are huge, candles at home, everything. It's in our cars, it's in our clothes, it's absolutely everywhere. You can't avoid it. It's not a matter of avoiding and living in a bubble. It's a matter of reducing exposure wherever we can. And there's easy places, low-hanging fruit, if you will. So reducing plastic use. Don't drink your water out of a plastic water bottle. Have a reusable stainless steel glass bottle. Those are great.
Mm-hmm.
Or starting to choose household cleaning products or laundry detergent that is fragrance free. Okay, so I know it doesn't smell as clean, but it is overall better for your health.
And I know some people even talk about like the trimester or the period where you're optimizing your health before you even start to try. And with these two factors of genetics and like lifestyle, when do you think it makes sense to dive deeper into genetic testing beyond what you know about your genetics? And lifestyle wise, how do you feel like stress plays a role into all of this too?
So, starting with the first question, it's unfortunately there are no real genetic testing panels to see if there is a genetic contribution to your infertility, with the exception of a few things. So, there's all sorts of different types of genetic testing we offer in the world of infertility. The first has nothing to do with infertility, it's called genetic carrier screening. With genetic carrier screening, this is a blood test to see if you have any variants, which colloquially is known as mutations, but they're really called variants. And these variants can cause medical condition in your offspring. Now, some of these variants that we discover in this testing can contribute to fertility. So, for example, with me, when I did my genetic carrier screening, it showed that I had two mutations that contribute to non-classical congenital adrenal hyperplasia, or NCCAH. This entire time as a fertility doctor, I thought I had PCOS for years. And I didn't do this testing. I didn't do expanded genetic carrier screening. And it wasn't until when I did it that I discovered this isn't PCOS. This is genetic. This came from my family. This explains why my mom had the exact same issue. And it took her years to have me, and went to so many fertility doctors, and she had all these struggles in conception, but it turned out that there's a huge genetic component here. So we can identify these things, or for example, something called Fragile X premutation. So Fragile X syndrome is the most common inherited cause of intellectual disability in boys. Okay, and autism as well. But for girls, it doesn't affect them intellectually. If they have a premutation, meaning it's before the full-blown syndrome, they are just women who are living their normal lives, and they may end up entering menopause prematurely. I'm talking even in their early 30s. So if you discover that you have this, it's imperative that you freeze your eggs immediately if you're going to delay starting a family, because you may not have as much time as your peers. But so there are these things we can discover with genetic carrier screening, but for a lot of causes of infertility, especially one of the biggest culprits being unexplained infertility, which accounts for up to 15 to 20% of infertility cases where all testing looks perfect and normal, we don't have a particular genetic panel to see, hey, is there a genetic contribution to your infertility? There probably is, and we know about some really rare mutations that exist, but they're not commercially available to test. People are working to change this, but it's still not yet available.
Dang, I need to go get my genetic testing done because my mom had a hard time having a baby, and she never really, well, having me, it took like 5 years. And she never truly found out why. And I'm sure that there are a lot of women that are eventually able to have babies, but not necessarily knowing why. And there's probably the root of genetics that's at play that might not have been tested years ago.
Yes, and genetics is a huge piece of it. We often say in our world that we can't really change biology, but we could try to minimize, or I should say optimize, how good your fertility outcomes can be through lifestyle. And then you ask me, how much of a role does stress play? And unfortunately, this is the $1,000,000 question, because it's really hard to quantify stress. How I feel stressed may be different. How somebody else feels stressed and how we manage it is also different. For sure, there's going to be some contribution. So now, infertility is not a mindset. Just because you're an anxious person doesn't mean that you're going to suffer from infertility. However, our susceptibility of stress impacting our reproductive outcomes varies, and it's going to affect some people. So I think it's really triggering when people say, well, just relax and it'll happen, because that's not necessarily true at all. And it's really minimizing the fact that this is a medical diagnosis. But in the same time, I do have patients that are extremely anxious who are having a really hard time succeeding despite being a relatively good prognosis in terms of their fertility. So I think that there's for sure a contribution there. If you're extremely stressed, we already know that women who have mental health issues that are not well controlled in pregnancy tend to have poor pregnancy outcomes. They're more likely to suffer pregnancy loss. They're more likely to have preterm delivery, more likely to have C-section and even delivery complications. And this is where the American College of OBGYN stresses that you are better off taking whatever psychiatric meds are needed to help you with your mental health in order to have a healthy pregnancy. And the risk of not being medicated tends to outweigh the risk, the benefit, and you're better off being on the medications. So we know that that is definitely a factor. And so if it's a factor in pregnancy, it likely will also be a factor in fertility. So if you're someone who is really mentally really truly struggling with generalized anxiety disorder, major depressive disorder, and all sorts of other mental health conditions, you need to get that in check. Normal day-to-day stress that we deal with it's part of life. You can't eliminate that. I think that if our daily stressors would cause our infertility, we just wouldn't survive as a species. We are made to be able to be resilient enough to handle day-to-day stress. It's just a matter of how intense is this stress? Is it chronic? Is it lingering? Is it always there and never leaves you? Then it's probably going to contribute in some way. But that is so hard to quantify, because even checking cortisol levels is extremely unreliable since it's fluctuating throughout the day.
Well, even if you think about it, if women are more stressed out in different seasons, they might not have their period. Or we talked about this hypothalamic amenorrhea, where you don't have your period for a prolonged period of time due to various stressors. And it's crazy how many women and friends that I've talked to who have had periods of missing their period due to like stress in their life or underfueling or overworking out. So I'd be curious too if like you've seen more of that in your practice over the years too.
So that is like real stress we're talking here. Okay, so the low grade chronic stress is really unlikely to contribute to anything. However, if you're dealing with acute stress, okay, something suddenly happened, whether it's a loss in the family or in your life causing grief, that's a major stressor. If you are having energy deficiencies, that's a major stressor that can contribute to something called it's like the female athlete triad. So a lot of athletes, if they are under fueling and they're over exercising, then the first thing the brain is going to think, I could barely fuel my own body. I am in an energy deficit, and therefore I can't feed a human. Therefore, the period must shut off. And so the brain sees this and shuts off the signals. That's why it's hypothalamic amenorrhea. Because what most people don't realize about the menstrual cycle is that there's something called the hypothalamic pituitary ovarian axis, which is basically like a 3-organ communication system. The hypothalamus is the control center of the brain. And that is responsible for the production of several different hormones that are signaling hormones. They then shoot another signal to another part of the brain, which is called the pituitary. And then the pituitary then is the messenger that responds by sending another signal to the ovary. So in the case of reproduction, you have something called GnRH, which stands for gonadotropin releasing hormone. It's a hormone that releases a signal to then release gonadotropins. So gonadotropins are what? Gonad signaling hormones. Okay, so that means FSH and LH. FSH stands for follicle stimulating hormone. It's a hormone that stimulates your follicles. And then LH is luteinizing hormone, which is the hormone responsible for ovulation. So GnRH sends a signal to the pituitary to release FSH in the beginning of the menstrual cycle. FSH will then cause the ovary to recruit one egg. And once that egg is ready, it sends a signal back to the brain and says, hey, I'm ready, through estrogen levels. So then the brain will change its pulsatile activity to then preferentially cause the secretion of LH, because it's the same hormone that causes FSH and LH release. How does the pituitary know to release FSH versus LH? It knows it through the pulsatility and the amplitude of GnRH. It's all very complicated, but basically, you know, once you have an egg recruited, LH will then cause the release of that egg. And that is how you have a chance, if you're having sex, to get pregnant. But if the brain knows, okay, cortisol levels are exceptionally high, we're stressed, or I am undernourished, and through energy deficits, you also have increased cortisol. It affects your thyroid hormone as well. And anything that impacts thyroid function that causes a surge in your cortisol levels, that throws, off the homeostasis of your endocrine system, your brain knows it. And it will inevitably cause a shutdown of the gonadotropin signals so that you do not ovulate. And that's how you end up with hypothalamic amenorrhea.
Yeah. I mean, in a healthy world, it's like an orchestration of all of these coming at play. And it's just, if you think about the percentage, all of your eggs and then the number of sperm to be able to have a baby, it's also wild. So let's touch on that too, of the male is the other side of the equation too. There has to be a sperm no matter what kind of couple you are.
Totally.
So what are those factors there that influence fertility too?
So there's so many different causes of male infertility. And so the first way that we check to see if a man has seemingly good reproduction is through a semen analysis. So the testing for men is actually a lot less comprehensive than it is for women, because the first screening tool we have for guys is just the semen analysis before we even check hormones. If a semen analysis is really good, then you know that most likely everything is functioning well. But we do see that in at least 30% of infertility cases, it's male-only factor. And then in about 30% of infertility, it's a combination of female and male. So a third is female only, a third is male only, and a third is a combination of the two. So this is why it's so critical to check the guys for their fertility as well. They can never be missed because they are half of the equation. Now, a semen analysis is a bit tricky because it's just a very superficial way of checking fertility. Oh yeah, okay, we got good concentration of sperm. They're swimming really well, which is called motility. And then when we take them and really look more closely under the microscope, a lot of them are really good in morphology, meaning the shape of the head and the tail is really promising. But the reality is there could still be some microscopic things going on with the DNA that we're not able to really see. So for couples, for instance, who are suffering recurrent pregnancy losses, we could do more advanced sperm testing, which is called DNA fragmentation index, which is looking at the oxidative stress of the sperm and how it's impacted the DNA. And so a lot of patients who don't even have that history will ask to get this testing done because they just want the most comprehensive test that they can get. And if DFI is high, then we know there's oxidative stress. We got to do something about it. There could be, anatomic causes of male infertility. There could be hormonal causes of male infertility, but there's also, toxin exposure. And believe it or not, really big culprits that I see on a regular basis is smoking cigarettes. People are still doing it. Vaping. I don't know why everyone thinks that vaping is less harmful than smoking cigarettes. It's still terrible for egg and sperm health. Marijuana, very bad for sperm, and then alcohol. So everyone thinks that alcohol is just this minor little thing. You know, we've socially made it so that it's normal to drink on a regular basis or drink on the weekends. You may not drink all week, but then if you're binge drinking on the weekends, it's really bad for sperm health. It's going to affect it. And so elimination of these toxins is really critical for improving fertility. Same with diet, same with exercise, a combination of cardio and resistance training. And then for your diet, once again, I always stress Mediterranean style diet because it is really the easiest thing to understand what a, sort of an ideal diet is. It's just minimizing ultra processed foods, focusing on whole foods, primarily based on vegetables, a good amount of seafood for your protein, less on, the animal proteins that come from poultry and red meat.
Yeah. I've heard saunas is another one for men.
Saunas is another one. The male reproductive specialist will always say, if you really want a sauna, you got to put an ice pack by the testes, by the scrotum. But otherwise, ideally, no saunas. But cold plunge is okay.
There you go. Well, there's a workaround.
You got one of them.
There you go. So to your point too about like one of the primary things you help your clients do is optimize their fertility. When do you know when fertility and ovulation, or rather ovulation, needs to be optimized versus going the route of having more involved treatments like IUI or IUF or IVF?
So it really depends on what we're seeing in evaluations. So some easy ones for IVF, for example, or let's start with IUI. If we're dealing with unexplained infertility by definition means that you're ovulating regularly and that you are relatively younger in age, you have at least one open fallopian tube, and we have adequate sperm. It doesn't mean that all sperm parameters have to be perfect, but if you're pretty close and everything looks fairly good, then like let's say concentration is really high and motility is really high, but the morphology, which sort of indicates quality, is a bit on the lower side. I take that with a grain of salt because what people don't realize is that when we have a sample of hundreds of millions of sperm, we're only taking 100 sperm to look at the shape and determining the quality. So the 100 sperm, it could be a coincidence that those 100 aren't great in comparison to the hundreds of millions. It's just a tiny size. So if all other parameters look really fantastic and morphology is a bit low, I still count that as unexplained infertility. And treatment for that is empiric, meaning that we start with ovulation induction plus insemination. So that's a perfect example where it makes sense to start with insemination, unless the couple really just wants to be as aggressive as possible right off the bat, or even preserve embryos for future siblings. So usually we'll start with IUIs there. If there's mild male factor infertility, it's also appropriate to start with insemination. Or it could be something as simple as like a couple just doesn't want to have as much sex, and so we need to do IUI. And intercourse can be difficult for some women due to various disorders, and things like, vaginismus can deter them from wanting to have penetrative intercourse. And so this is where IUIs can actually really come in handy. In the case of tubal obstruction, so if we know that the fallopian tubes are diseased, then natural conception is very difficult to occur because fertilization happens inside the fallopian tube in nature. So if you have blocked tubes, if you've previously tied your tubes, or you have really swollen and diseased tubes, usually due to endometriosis or history of a pelvic infection, then you need to just jump straight to IVF. Because if the anatomic piece of where fertilization occurs is not working, we have to bypass that. And that was actually the main reason IVF was invented in the first place. It was for women who had blocked fallopian tubes and they were considered sterile. Another big indication is if you have severe male factor infertility. I always tell patients at the time of insemination, if we have a total motile sperm count less than 5 million, it's extremely unlikely to work. It's extremely unlikely to work. Person never really seen it work. And so in those cases, it's because male factor is more severe, we should jump straight to IVF. And not just IVF, we need to take the best looking sperm under the microscope and directly inject it into the egg. And that's known as ICSI, which stands for intracytoplasmic sperm injection. So those are some of the indications. It could be doing IVF for genetic testing. So if you know that you're at risk for passing down a pretty severe medical condition, for example, if I have someone who is going to have Huntington disease because they tested positive for the mutation and they don't want to pass it on, we can create embryos, test those embryos, and make sure we transfer the one that is not affected. Same with all sorts of other diseases like a BRCA mutation for breast cancer. So that would be another indication. There's so many different ones. Of course, doing reciprocal IVF for same-sex female couples, doing IVF for same-sex male couples would be another indication. Sometimes for transgender people, depending on what medications they're taking, if they're on certain hormone therapy, that makes it so that they would need a gestational carrier, then, IVF is usually the answer. And then simply for fertility preservation. So IVF, if you are in a committed relationship where you're going to have a child with this person, then it is appropriate to make embryos and freeze them for the future, like what I did with my husband when I was 32.
Mm-hmm. How early do you think couples that know that they're in a committed relationship, or even women that know they want to have babies, how early on, I mean, I'm sure there are a myriad of factors, should they consider freezing their eggs?
So, the textbook answer for freezing your eggs is usually the earlier the better. And the main reason for that is because egg quality is always going to be superior when you're younger. And when I say when you're younger, I'm really referring to late 20s, early 30s. For the late 20s, unless there's some exceptional cases, it's really not necessary and not worth it to freeze your eggs unless, for instance, you've been diagnosed with cancer and you need chemotherapy and you know that you may lose your fertility, or if you know that you have some sort of medical condition that's going to really significantly impact your ovarian reserve in the near future. But usually, the sweet spot for me is early 30s. That's where you get the most bang for your buck. Okay, because your ovarian reserve is going to be higher than it's going to be in the future. Your egg quality is also going to be better than it will be in the future. And so you may be able to get away with simply just doing one egg-free cycle. Usually, if you postpone, I have women in their late 30s that come to me for egg freezing, and that's totally fine, and they can do really well. But at that age, you're talking most likely you're going to have to do at least 2 egg-free cycles, possibly even more depending on what your ovarian reserve is. And the reason for that is because the older you are, the more eggs you need to make high quality embryos to give yourself a meaningful chance at a baby. And we cannot predict what these eggs are going to do in the future. We really have no idea. And we don't even know what sperm may look like in the future, because even if, let's say, you are in a committed relationship and you choose to test your partner's sperm just to know where he's at, his sperm can change later on. Your partner can change later on. You never know what's going to happen. The whole point of freezing your eggs is that you're securing your own fertility. And so on average, if you're under age 35, it takes about 15 to 20 eggs to give yourself a 95% chance at one child. One, not two. Takes a lot of eggs to give yourself a high chance at one child. So what I usually tell patients is if your goal is to have 2 kids and you are not risk averse, you want to maximize your chance of really having this happen for you, you're looking at about 30 eggs to freeze if you're under 35.
So in terms of success rates of getting pregnant, can you walk us through what are the success rates of getting pregnant naturally, IUI, IVF, and how does that change as we age?
Okay, great question. So naturally, your highest chance of conception in a given month is going to be 20 to 25% in your early 20s. It starts to decline usually around 23, 24. Some studies showing 25. So it just depends on the study you're quoting. And from there, every year that passes by, that chance goes down a little bit. So that, for instance, once you're in your mid you're looking at about a 15% chance of conception per month. Once you're at 40, you're looking at about 10% chance of conception. And then as you get further into your 40s, usually by 45, it's really plummeted to below 1%. Natural conception really drops. With IUI, believe it or not, the chance of a pregnancy is really not that different compared to natural conception. So everyone thinks IUI confers this huge advantage, but it really doesn't. And even the number I quote, young couples with unexplained infertility, large clinical trials show us that with unexplained infertility, the chance of an IUI working is about 9 to 10% when combined with ovulation medications. 9 to 10% per cycle. It's not very high.
Oh my
Now,
God.
it is higher,
No.
for instance, for lesbian couples who are doing IUI because they have no history of infertility. Or, for example, single women who are pursuing single motherhood by choice using donor sperm. Those IUIs tend to be very successful if they're younger because there's no history of infertility, right? And so in those cases, you're looking at about 20 to 25%, which is the baseline for natural conception. But if you're dealing with infertility, that chance definitely goes down. And to sort of backtrack a little bit with natural conception, so unassisted, by 6 months of trying, 80% of couples will conceive. So if by 6 months you did not conceive, your chances of conception in the second 6 months is much lower. And this is why I do have a lot of couples who know this. They come in at the 6-month mark being like, yes, I know I'm young and I haven't tried for a year, but it's been 6 months. I want to see what's going on. And I think that that's perfectly appropriate.
Yeah.
So now with IVF, of course, this depends on age, but for women under 35, one IVF cycle usually yields about a 65% chance of success. So very high. But of course, as you get older, that success starts to drop. So our IVF success rates are higher than they've ever been. We're sort of plateaued and we're having a hard time get above that pregnancy rate because at the end of the day, we are dealing with infertility, we are dealing with people's biology, and we're also dealing with age as a huge contributor to the increasing infertility rates that we're seeing because we're trying later and later than we used to. And we know that, for instance, at the age of 40, it takes about 3 IVF cycles to yield a 40% chance of success. So very different than when you were under 35. Those 5 years from 35 to 40, a lot changes. And it's really hard for a lot of women to really comprehend that because nowadays we look younger than ever between sunscreen use, Botox, filler, all the interventions we're doing in terms of everyone is doing a much better job of not smoking, drinking less, sleeping better. There's been a huge shift in our generations for lifestyle. And it's become sort of, and I love this, it's become cool to prioritize sleep and not drinking and exercise and eating healthy. So we're looking great and we're feeling great. And everyone is assuming that the ovaries should also respond to that change in lifestyle. And it does, but to a certain extent, because if I'm 38 years old, so are my eggs. I've had the same eggs since I was born. And they've been exposed to all the pollution, to all the stress, the sleepless nights, the binge drinking nights when I was younger, the junk food eating when I was in college. All that stuff has contributed. And then also, aside from lifestyle, there's just biology, right? We know that, for instance, in our mid-20s, most women are now starting to use anti-aging creams. They're using retinoids so that they can keep their skin young. Why? Because the collagen in your skin is starting to break down in your mid-20s. Well, it's the same thing with the proteins that hold your chromosomes in place. This is what a lot of people fail to understand. It's not just mitochondrial function. And you can't just slap on some supplements to try to reverse the mitochondrial aging because it's not just about the mitochondria. It's about the chromosome number. So we have 2 copies of our chromosomes that are aligned in the equator of the egg. And what's holding them perfectly in place are these little finger-like projections called spindles. So there are these proteins, they hold the chromosome pairs in place, okay? And all these chromosomes should be held together. And when you go to ovulate, the spindle pulls the chromosome pairs apart, and then it kicks out a copy of the chromosomes and holds a copy in place. But because these proteins get weaker over time, the segregation of chromosome pairs becomes an abnormal number. So you may end up with extra chromosomes or missing chromosomes, and it's that abnormal chromosome number that leads to an abnormal embryo, and then you either don't get pregnant or you get pregnant and it results in a pregnancy loss.
So the next level of the conversation isn't just mitochondrial health, but it's that chromosome health that needs to be had.
Yes.
Maybe that's what you're bringing into 2026 more
Yeah, I
so.
mean, it's people need to understand it's really the chromosomes. That is the main culprit, more so than mitochondrial health. Of course, that's important. And of course, you can probably move the needle a little bit with antioxidant supplementation. And I'm a big fan, and I personally supplement it myself because why not? I have
Yeah.
nothing to lose by taking CoQ10. Of course, within a certain dose, you don't want to overdose. But in the same time, you just cannot change biology. And this is just how we were made physiologically as humans. We do have a limited reproductive lifespan, and that's probably on purpose because at the end of the day, we have to live a long enough life to take care of our offspring. And so we can't continue to have children until we die, and then there's no one to take care of them, right? So this is probably why our ovaries are aging twice as fast as we are. It's to take into account the fact that humans, they need to be taken care of in the first several years of their life. We're not like other animals where, after a few months the babies are on their own and they leave the nest.
Yeah. Well, I mean, it's just like all so powerful, and you're just such a wealth of knowledge and so empowering. What would you say are the top 2 to 3 things you wish every couple understood before they started trying to conceive?
I would say that if you are trying to understand your reproductive health, you do not have to wait to understand it. Empower yourself by understanding how to track ovulation, looking into your sperm, making sure that everything is functioning before you even start trying, so that if you do find something, you can do something about it early on. The other thing is, to really understand how lifestyle plays a role. And so just trying to optimize as best as you can, but without creating stress around it. You don't have to be paranoid and thinking that everything that's suboptimal has negatively impacted your future fertility or the health of your future offspring. We're looking for consistency, not perfection. So if day to day I'm prioritizing limiting my processed food consumption, but it's the holidays and I want to enjoy some donuts and I want to enjoy some cake for dessert after a big meal, enjoy it. Don't feel bad about it.
Mm,
Give yourself grace through the process. And then the other thing
yeah.
to remember is that if you are a couple, it's obviously different if you're an individual deciding to do this on your own. But if you are a couple, it's really, really important that you do this as a team. I think that a lot of the mental and physical load lands on the female partners. And at the end of the day, you guys are going to be parenting the children together. And so that starts from preconception.
Mm-hmm. Yeah. How do you support couples in the emotional aspect of the fertility journey?
It's really tough. I mean, for me, I really spend a lot of time with my patients. So, it makes me fall behind in clinic a lot of days because I really try to give them all the time that they need to help support by answering questions and giving them whatever knowledge they need. But the other aspect is that I really strongly encourage couples who are really, you know, they're in the gutter emotionally and they don't know how to cope and handle this. I often encourage them to seek additional help. There are amazing therapists who are specialized in infertility, as well as psychiatrists who also do the same. So I know you had introduced me to Jessica Zucker, and she ended up coming on my podcast, and she's incredible. So I do send patients to people like
Yeah.
her because I think that even just in my conversation with her, like, man, you just reframe things in a way that takes away shame, takes away guilt, makes you realize that you can have a different perspective that will make this journey quite a bit easier. So it's important to seek help when you need it and not think, well, I can just handle this on my own, or I don't really believe in therapy. I don't think anyone says that anymore, but I think that finding the right therapist through this can be life changing.
She's amazing. And it's like you need to have your crew and
Yeah.
your community to support you on this
Yeah.
journey too.
I think that by talking a bit more, it reduces the shame and that
Yeah,
people are more willing to find that support system in their community.
definitely. Reducing
Yeah.
the stigma. Is there any recent research that you're excited about?
I would say one of the things I'm most excited about is seeing how much information we're going to gather from doing whole genome sequencing. So this is a whole new thing that is being tested for in the setting of IVF. When we're biopsying embryos and genetically testing them, we usually just test for whole chromosome number, but even chromosomally tested normal embryos are still not working. And the question is why? We tend to blame the female body and the uterus way more than we need to. I think that more often than not, the
Yeah.
source of failure comes from the embryo itself, but we just need more answers from the embryo. So there is a new company called Juniper, and I'm really interested to see when they start putting out their success rates and what that's going to look like, because they are looking at the entire the entire genome of an embryo to see if there are
Yeah.
small DNA changes that could reduce the viability of that embryo. Also looking at new mutations that occur after embryo development occurs. So it doesn't come from the parents, it comes from the embryo cell division. So as we gather more genetic information from these embryos, I'm curious to see how that changes the pregnancy rates, because the number one most difficult situation after an embryo transfer is calling a patient and saying, the transfer did not work. And patients always feel so optimistic because they're like, well, if my odds are 70% of a pregnancy and I'm part of the 30%, what does that say about me? And I think being able to provide more answers for that will really help these couples.
Yeah. And it's also not a secret that fertility treatment can be costly. At times, do you think there's going to be any changes in the future to create more
Yes, so
accessibility?
at least in California, there definitely is. They passed a bill that actually starts being implemented in the new year. So we are expecting a dramatic shift.
Fresh off the
Yes.
press.
So I tell all of my patients before they start coughing up their own money, call your insurance and see what your coverage is going to look like in the new year, because there's a good chance if you work for a larger employer or a bigger company that you are going to have, I think it's 3 egg retrievals, 6 IUIs, and unlimited embryo transfers. And there's also support for the LGBTQ community so that if they need help with, I still don't know what that looks like in terms of egg donor, sperm donor, or gestational carrier, there's going to be some sort of support there through insurance as well. Yeah.
That's amazing. Wrapping up, what would you say lights you up and spurs you on to continue to do this incredible work you're doing?
Honestly, I've always been so passionate about reproductive health. I come from a family who has suffered so much infertility, and aunts who are childless not by choice. And so that's always given me so much passion behind this career. But what has made it level up even more, that makes me so excited about this field, is having my own babies, knowing how fulfilling and how much it's changed my own life. Anyone who wants that, I want to help be able to provide that for them if it's become difficult.
Mm-hmm. Well, you are such a light. Where can listeners connect with you, learn from you, and work with you?
I'm a little bit everywhere, so you can find me mostly on Instagram at Sasha Hakman MD. You can also find me at my website. It's also sashahakmanmd.com, where you will see blog posts and podcast episodes that are released. My podcast called Trying to Conceive with Dr. Sasha Hakman is on all platforms, including Apple, Spotify, and YouTube.
Amazing. Well, you're such a wealth of knowledge. Thank you so much for this conversation today. It's been so fun
Thank you.
having
Thanks
you.
for having me.
Thank you for tuning in to the We Shine Well podcast. If today's conversation lit something up in you, I'd love for you to share it with a friend, leave us a review, and dive deeper each week by subscribing to our Substack in the show notes to interact with guests and discover more resources to expand you. Until next time, keep trusting your right next step and keep shining, my friend.